is used whenever you want to increase hip extension. You're typically going to be stretching the iliopsoas muscle. So to do this, you're going to have your patient sit like with their glutes half on the table, half off of it. Whatever leg is going to be stretching is the one hanging off. The non-affected leg is going to be the one where they're holding on to. So you're going to cue them to bring their non-stretching leg up. So you want to bend that and interlock the fingers. And you're going to have them lie on their back here and let that leg hang all the way off. So just keep in mind that if you have a patient that has pain whenever it comes to extension, like in their lumbar area, so then, yeah, thank you. To avoid the stretch because it can then cause them a little bit more harm to their spine. Oh, I'm sorry.
It's there for you.
Okay, hold on. There we go.
Can you just tell us why the position of your other, in this case your left leg, why does that matter? What are you doing? By holding your right leg.
If I'm here, if I'm anterior tilting, nothing, posterior tilt, you get a deeper stretch and you feel it literally all through here.
And if we wanted for her to stretch the rectum instead of the iliopsoas, what would we aim to do?
Bend the knee.
Perfect.
In front of you. And then the leg you do want to stretch is going to go behind you. You can do like a slight bend to the knee. What you want to do is shift your weight forward until you feel the stretch coming right here. It's going to stretch more of your iliopsoas.
Shift your whole pelvis rather than just your shoulders. There we go.
Okay, and then you should feel it right here. And then you're going to squeeze the glutes to get the posterior pelvic tilt. And it hurts so bad.
Pause there. So we're managing the pelvis two ways. The first way is by positioning, we're stretching right, by positioning the left hip inflection. That passively posteriorly rotates the pelvis. The second way was that verbal cue to the patient, squeeze your glutes, that actively positions the pelvis. So we're really trying to hold it and support it in position to optimally stretch the flexors. Before you move on, I want to call everybody's attention to the picture in the book. Figure 2011 has a mistake.
I'm so glad you asked. Alright, so you're going to get down on one knee. This way. Alright, so again, the leg you don't want to stretch is going to come in front of you, and the leg you do want to stretch is going to be behind you. We want to bend the knee to get more of a rec fem stretch. And so same thing, you're going to shift your body weight forward until you feel a stretch. Squeeze glutes. Oh, that hurts. And then if you want more of an even more stretch of the rec fem, you can grab the, I didn't like that at all.
Can you go back there one more time? Sorry, you don't have to grab your ankle, but just kind of show us the position again.
Yeah.
We will run into folks in this room who are super flexible and struggle to feel this. If you're not feeling these stretches, take the downside, in this case your right arm, and bring it overhead and kind of overhead and side bend away. Think about the psoas major. It originates on the transverse processes and discs and bodies in the lumbar spine. So we can elongate it a little more that way. If you're struggling to feel this, throw that in. Did it change it for you?
Yeah. I'm really tight. I did cycle yesterday, so I'm feeling all of this.
Did you run to school today as well?
No, I took the car. Thank God.
Very nice. So
Side that you're trying to stretch is going to go over top. You're going to kind of stabilize the ankle on the opposite leg and press into the knee to feel a stretch. If they aren't feeling much, leaning forward will help to increase the stretch. You feel it kind of like right through here. And then the other variation is in supine. So kind of same positioning. You can do it like this. Or to increase the stretch, you can reach behind the femur and behind the knee and pull it up toward your chest. And stretches through the opposite side on this side. That's it.
And if you want to stretch this hip, you bring it cross over and then just bring the knee in medially like this. And then the second variation is supine. You bring your knee to the opposite shoulder to increase internal rotation.
This one we have done before and we always usually do. I'm pretty sure it's really common. For this one, you're going to take your ankle in your hand, try to keep your leg and your hips even and your back not arched completely, and keep a posterior pelvic tilt, because if not, you're going to eventually hold on. Woo! Sorry.
How?
the posterior pelvic tilt? What are you gonna get your patient to do?
My leg's really tight and I'm like trying to keep a good position. I wrote it down. You can, if you don't keep the posterior pelvic tilt, your patient will completely extend their back.
But how would you tell them to do it?
And if they can't keep their foot up like this, they said in the book to either keep it on a chair or put it on a table for extra stability, rather than grasping your ankle. Good?
Yes.
That you want to stretch on the door frame and then your other leg through the entrance of the door. And then you just put it up like that. And if you want to increase the stretch, you can scoot your butt closer. And then you can even practice hold relax agonist by squeezing or by pushing into the wall and then lifting up your leg.
Did everybody catch that? Hold relax or hold relax agonist contract.
And then you just, with a straight back, you just lean your trunk forward. That's it.
Can you walk us through the difference between doing it unilaterally as you demonstrated and what would happen if you did it bilaterally?
Let me show it.
I think it's probably easier if you show it.
Okay, so when you have one leg up, you're maintaining an anterior pelvic tilt, or actually like this. You have anterior pelvic tilt versus if you put both of your legs up, then your pelvis is posteriorly tilting.
So for your patient who's really flexible, you're more likely to be able to elicit a stretch if you keep the pelvis anteriorly rotated by way of the contralateral lower extremity and extension.
Hip flexor, adductor, and internal rotator. So you're gonna do the opposite of those motions. With a hand placed on the wall, your foot is going to externally rotate. You're going to bring it behind you, almost like behind the foot. And your hip is going to go towards the wall to stretch the TFL, and then you have a very fancy pose. You know what I'm saying?
There's different positions that you can do this in, but I'll just attempt to hit the sideline more, just holding here. Starting with the knees and ankles together.
Hang on, you're on camera.
I'm on camera?
You're on
Oh,
camera.
I'm not? Okay.
I'm sorry, yes, you're on
All
camera.
right, what was I saying? Knees and ankles together. Then you keep the ankles together and just raise the knee on top. And back down again. You can also do this supine and eventually progressive side lying and then a modified bridge or side plank position. You can also add resistance by tying bands between your thighs or adding a weight to the top leg.
It'd be helpful to see those. Alright.
And this is significantly harder. Down again.
So can you do a few more reps? I want to pay attention to a common movement problem. So a lot of times people think, if I go this far, it's good. If I go a little further, it's better. We talked about that at the upper extremity summit. So people will go really, really far. Go as far as you can this time. Yeah. That's not hip external rotation abduction. That's lumbopelvic rotation. So make sure that you're watching for your patient to recruit movement only from the hip. And then a little strategy, if they're having trouble motor planning that and they keep rotating their trunk, tell them to push their top knee forward just a half an inch. Keep it just out in front that much. And then do the motion. And sometimes that helps to cue the lumbar spine to not rotate. All right, good.
For this one, sorry. You're gonna have them standing. She can use the table so she doesn't like fall over, especially if she's got a doo-doo balance. So I have, if you have the resistance is coming from the table, like from the band. So the resistance is like pulling her towards the table. So it says to resist extension of the hip. It says have the patient's face towards
the resistance, requiring stabilization of the anterior muscles on the stance leg. So she's just gonna bring her leg back, and then back. I don't really understand why it's requiring the stabilization of the anterior muscles either. Do you want me to be honest with you? Is it just
So
so
let's start with, what leg is this exercise being done for?
Leg sensors.
Which leg, right or left? The left. And I think it's the first thing, because intuitively we see the right leg moving, we're like, oh, it's a right hip extensor exercise. But not in this case. We're using this as a way to challenge the stability of the left hip. Does that make sense so far? So we're doing stabilization. Said principle says if we need to work on stabilization, we should train it through stabilization. Yes, sir.
Is this a good exercise for?
Of the moving thigh. Have the patient face away from where the resistance is secured. So would you face away? So we're resisting hip flexion with the right leg. This requires stabilization by the posterior muscles on the stance side. So we're gonna do some right leg hip flexion. I want you to make a mental blueprint of where you feel it. Do a few of those. Second bullet, now we're gonna have you turn around. To resist extension of the moving thigh, have the patient face toward where the resistance is secured. This requires stabilization by the anterior muscles on the stance side. And so I want, rather than for us to just try to memorize that, for everybody to do this, facing both ways, and try to appreciate the difference on the stance leg, and then we'll come back and we'll finish this. Get funny.
Oh no.
All right, so if I'm doing this, and it pulls me back, what's that motion? At the right hip. How do I prevent flexion?
Extension.
With my extensors. Doing this. What's that motion? How do I prevent extension?
Flexion.
With my flexors.
So the
So
direction.
put some tension in it and feel what it would pull regarding your stance leg. And we're just preventing it. You gotta put some tension in it. The blue one, that's the unaffected or stronger side. This exercise is done for the stance or stabilization leg, and we know that in motion analysis, stabilization means isometric contractions, means no meaningful movement. So what we're looking at is what's not happening on the stance leg. Ready?
Okay, so keep your leg back. You're looking at her stance leg. It would pull her stance leg hip into extension, so it's working her hip flexors as stabilizers. And then
Can I read from the book?
Yep.
Perfect. Keep doing that. A couple more reps. Second bullet point that we read, to resist extension of the moving thigh. Again, we're resisting extension of the moving side. Have the patient face toward where the resistance is secured. This requires stabilization by anterior muscles. Read as hip flexor muscles. Perfect.
okay, and then as she brings her leg out, so to resist hip flexion of the moving thigh, the patient faces away from where the resistance is secured, which requires stabilization by the posterior muscles on the stance side.
That one's hard. Good job.
Mm-hmm.
Good job.
The hat turned downward. So if her, so if her right side, if her left side is dropping, we're gonna be working on her stance leg, because when she's in her stance, it's gonna drop, right? So we're trying to work on it to get back up. And here, if you could just point at your top ASISs, hold it here.
Yeah, hold me up.
Just so you can see it better, because you want to make sure that it's just the pelvis moving and they're not bending their knee. So if you bring your knee together,
You bend, you really
you're not really working at the abductors, you're kind of just working at your knee flexors. But
You need extensors.
knee
You know
extensors,
what I
sorry.
meant.
Yeah. So this is working the concentric and eccentric movements of our
burning.
stance.
Right? And you're young and healthy.
It's
and
burning.
you feel
Yeah,
this.
woo.
And it's also working the involved side that needs strengthening.
You guys get it, right?
And
I want to modify one more thing. Eccentric control and concentric. On the
so
descent.
eccentrically on the descent, and then concentric on the way up. And if they are unable to do this, you can do isometric. So you can just hold here. You can hold on.
Dr. Miller gave us an example in the hallway like
That
this.
was the example he gave me. So, so you can not do that, but you can hold it here. So you could just hold it, and bring it down, and then you could count that as like 1 rep.
Yeah.
You can do whatever. You could bring it to the inside, just hold it, and to the outside.
Awesome. Alright, so we got clamshells.
You would like to do is you want to cue the patient to drive their heels into the table, and then bring their pelvis up while keeping their hands down. And this helps with strengthening of the hip extensors and then some trunk stability, because evidently you have to keep your trunk extensors stable so you don't have trunk flexion.
Which hip extensor is primarily active during this?
So the primary hip extensor would be your gluteus maximus, because you are creating active insufficiency of the other ones once you bend the knee, once you flex the knee. So your gluteus maximus is the one that's engaged the whole time. A progression of this is you can put a weight up top on the ASIS, or when they're going through their glute bridge, just add some resistance up top while they're going through it. Other ways to add resistance, like it was explained. Yeah, so you don't want the dusty one. This will add resistance with a band. So not only are they working on their hip extensors, they're working on their external rotators and their glute med. So there's the gluteus maximus resistance, glute med resistance, and then your external rotators, all of them. Another way that can be utilized, double check right here, is you can have them alternately extend their knees. So you can have a unilateral glute bridge, and then you can have each alternating knees moving to have that unilateral glute bridge for a little bit more of a challenge, helping with the proprioception, all those good things. Another challenging way is you can use like a medicine ball. You can have them go on a medicine ball, kind of lean back like this, and then they have that glute bridge action. And then you can also have them do.
They're both active when you're going eccentrically and concentrically. Oh. My backpack's there, my computer's there.
And if you fall.
And the foot vocal.
Okay.
Already.
Okay. Well, we're not using this one yet, so sorry. You went ahead of yourself. I'm not sure which
Or
wall.
maybe best if you pull that door shut.
Okay. You're gonna try to have your, at least your legs parallel with your shoulders around there, and then back is on. Ooh. Your back is on there, and then all you have to do is bring your legs a little bit out. And then all you're doing is just sliding, bending your hips and bending your knees. And then slide back up. So this is all working on your knee extensors right here. When you're going down again, and then up. And if it's a little bit like hard, if there's like friction, you can put a towel behind there. It's a little bit easier for them. And then, no. Yeah, that's that one. Compared to the door. So it kind of works with, it brings in a little bit more, it really is. Brings in a little bit more of these muscles, of the core muscles over here. And then also having your arms, you can also put cuffs as well, or anywhere that you want to add weight to it, it's a little bit easier. And then in the book, it also shows a little bit of coordination, where it's like you have one arm go down, while the other one also just stays up. Okay, so thank you.
Deadlifts, so stance leg and the uninvolved leg. For the knee position and the hip position, it's going to be 30 degrees, so 30 degrees knee flexion and then 30 degrees hip flexion. With the opposite hand, it's going to touch the toe, and then with the opposite, the uninvolved leg is going to like kick back, so it'll look like this. And then you have the hand on the same side as the affected leg on your hip, so it'll just look like this.
Excuse me. Like that.
then this is working the hamstring muscle. So long head, right fem, semimembranosus, and semitendinosus.
Long head biceps now. We know
Yeah.
what you meant.
Yeah.
Yeah, super common for ankle, knee, hip, and trunk rehab. Very, very common exercise.
And don't like hunch over like this.
If you look at the book, do it correctly, Eric, real quick, and just hold the static position at the bottom. Yeah, if you look at his lumbopelvic position versus figure 2031, there's a staggering difference. Do it like Eric, not the cartoon. The cartoon is just like a massive trunk flexion.
Would you use that pad if you want to add more?
Yeah, if you wanted to add more challenge, especially with the ankle. Can you do it on the Eric's pad since it was suggested? As you're doing this, I want to make a point, and we'll see it best from the posterior view. Can you face away from all of us? Look at his ankle inversion, eversion really rapidly. So super for ankle stability, particularly following ankle sprain, because it's making the eversion work rapidly. Much more
Is it more of a challenge?
ankle specific
Yeah, look at it.
than it was before.
I would have fell already, so it's okay.
Thank you.
They have this one with an assisted device, a cane, to work on your balance and lowering for balance and control, lowering your body weight. So you can hold the cane in the opposite hand to the leg. And this isn't in your book, I just do this just because I think it's a little more stable. And you wanna make sure your knee is not going over your toes, like he said. And you can start in small ranges. Don't judge my lunge, Dr. Miller. You can go small ranges first, and then it said you can go deeper into like a more 90-degree flexion. Did I do that right? My lunge is okay?
The posterior femur, as the tibia tips forward, the ACL is really stressed. There's a lot of tensile force going through it. So initially, at least for the first 12 weeks or so following ACL reconstruction, the knee should not pass the toes. For most of the rest of us, we probably have a lot more wiggle room than knees over toes guy says, or old textbooks used to say. This image, however, we're looking at figure 2030, does a good job of showing what a knee position would look like for that ACL patient. But my question is, how do we keep the knees back? Because we can't control the knees at the knees, so what do we cue our patient to do? Perfect, sit back. We can cue the hips. If the patient sits back, it drags the pelvis posteriorly and keeps the knees posterior to the toes. So again, at least for that ACL patient, our cue is gonna be sit back. That tends to be a position where, where the hip extensors, the glutes, the hamstrings are dominant in the motion. And generally, what we're looking at is that the angle between vertical and the torso is about 30 to 40 degrees. Which if you took a goni and you measured there, we'd have about 30 to 40 degrees. Not of trunk flexion, right? We're not here. It's from the hips. Spine is neutral, not vertical, but rather neutral. But from the hips, as compared to vertical, we're 30 to 40 degrees anterior. Does that make sense? Difficult to do this wrong in acute care. Eric's in the hospital. Don't know what was wrong, but he's really weak now. And I'm all excited. I'm like, all right, we're gonna do therapy. We're gonna get up today. And he's sitting in his hospital bed. I'm gonna help you stand up, okay? Really excited. I'm gonna get as close as I can, and on 3, we're gonna stand up. 1, 2, 3. Stand. Help me stand. Help me stand. Help me stand. What have I done wrong?
You're not letting him be able to.
Right, but how often do we get really close? Like I'm gonna maximally guard. I'm gonna be really safe. We're here. Okay, we're gonna stand on 3. 1, 2, 3. How about this? Like posteriorly rotate your pelvis, because nobody in a hospital bed has good posture. There we go. Now let's do this. Ready? It works. 1, 2, 3. Patient's a total assist times 2 at this point, right? In an acute care setting, this is important. Slide forward to the front. Good. Lean forward, lean forward, lean forward, lean forward. Ooh, that was easy, right? And then reverse it on the way down. It's really easy if we just get them to anteriorly weight shift. Pause here. We're like 30 to 40 degrees relative to vertical. You're good. This is really important in acute care, not just outpatient ortho. So, just picture you're at some big event. Supine factors are going to determine foot placement. Whether a patient's comfortable squatting, here with a little bit more narrow foot position, or sumo position, or something in the middle. What are we gonna look at, or what are we gonna wanna know more about to determine their optimal squat?
Which muscle they're gonna stretch, or
Which muscle? That definitely plays a role. Like the wider the stance, the more the adductor magnus can contribute.
The head of the femur into the acetabulum.
Yeah. Your acetabulum, your genetics, your acetabulum determines where your feet are gonna be most comfortable in a squat. So the way I squat isn't the way you should squat, isn't the way your patients should squat. We are gonna have a slightly different squat position as determined in great part by where the acetabulum sits. So big picture, it sits anterior, inferior, and laterally. But how far anteriorly or laterally is gonna determine whether somebody's comfortable with their feet more aligned here or aligned wider. Second thing, before we kind of assess acetabular position, what type of feature is going to determine how deep our patient's able to squat while maintaining good hip flexion and not moving from the lumbo-pelvic region?
the height?
Dorsiflexion?
Dorsiflexion is going to play a role, but what about if we just limit it to the hip?
Just
If we just look at the hip, how much flexion is allowed is going to be determined by what factor?
Femur length.
Femur's involved, depth.
Flexibility of their hip extensor.
Their muscles might play a role, but if they have adequate flexibility, relatively normal-ish femur length, good dorsiflexion, it determines the person who squats to here. Can you squat for us? This is good.
I'm not that good. at
Better
it.
than me. What determines the person who squats, keep a neutral spine and goes down as far as you can to there, versus the person who squats to here and then they're like, oh, I can't move any further, now I just recruit motion out of my pelvis.
The pelvic position.
What about the acetabulum? Let me narrow it down. It's a ball and socket, right?
As far as it's.
Yeah, the depth of the acetabulum is going to determine how stable or how mobile it is. So, an individual with a more shallow acetabulum, a more shallow socket, is going to have more mobility, but less what? Stability. Whereas a person with a deeper acetabulum is going to have less mobility, but more stability. And so, we're going to see tomorrow there's acetabulum differences around the world, and places that have a higher incidence of hip dislocation or dysplasia have a shallower hip, have individuals who are built to squat more deeply, and locations with a decreased incidence of hip dysplasia or dislocation tends to have a deeper hip that's not as effectively built to squat deeply. So we've got these factors that are going to determine how our patients should stand during a squat and how deep they'll be able to go. So how do we check for it? Great question. Mr. D, can we set up the back table for this? We're going to scour or feel the acetabulum, the socket, and see how easy movement is in different angles. So if we take his acetabulum and we try to feel just the inside here, and he squats with a really narrow stance, we don't get very far. It's like 90 degrees, right? If I internally rotate him even further, nope, I don't even get to 90 from there. What if we take him into end range horizontal abduction? We try that. No, this is not his squat position. What if we allow it to move a little bit more freely? Right there, that's where his optimal squat position is going to be. Right? It opens up right there and allows the femur to move maximally in the direction of flexion. I'm going to scour the hip that way. Anybody have super mobile hips in here?
Well, how?
You just got pointed.
It's nice, Todd.
Yeah.
It is.
Wildly different, right? We get
She not mobile.
all the way there. It opens up really quickly, and like even in just the sagittal plane, it's much more mobile. But once we come out here a little bit, easy. So you see, like we can determine depth of squat by just scouring the hip. Confirm that. So we're gonna put him with his knees close together to start. achieve a nice neutral lumbopelvic position, and just ask our patient to reproduce that squat motion, right, in an unloaded, unweighted position. When his knees are together, that doesn't look very good, does it? Don't love that. Spread out all the way as wide as you can make them on the table. Just rock back again, try to keep the lumbar spine neutral. I mean, that's a little better, but I think we can still do better. Maintain this lumbopelvic position. Again, unweighted, we're not squatting down, he doesn't have to manage his body weight, and we do a better job of keeping a neutral-ish lumbopelvic position, and this kind of reinforces the position from the scour. Ultimately, thank you. Ultimately, both of those should reinforce that we're having our patient squat in a put the knees. This motor pattern is not, right? Doesn't look very strong either.
Got the Disney. Demi Lovato.
Oh, so you have an idea. You have a problem with dynamic valgus. There was 3 described by your book. A side of it looks silly, so that makes it 4.
I mean, you're stressing the MCL.
Stressing the MCL, that's actually 5th one.
Oh.
Along with
The
patellofemoral pain syndrome, MCL, and what's the other main ligament there that can be irritated?
The
ACL and the piriformis. All those structures are correlated with injury from this dynamic valgus position. Mr. D had an idea. What'd you say?
Well, put the ball between your legs, that way you don't have to worry about it.
Now they can't go in. You like that?
I do.
My knees can't go in. No more dynamic valgus for me. You see some head nods? We like it?
Yeah, but like.
To concurrently adduct and internally rotate, which means when I get rid of the ball, what is my body now going to be reinforced to do? Oh, that stinks. Don't do that. So what can I do? Put a band. Let's recruit the abductors and external rotators, as in the image. And it doesn't need to be a ton of resistance. It just needs to be enough to provide a tactile cue. As you squat down, push your legs out into the band. And now all of a sudden we've got a cue telling us not to do that, but rather to do that. It doesn't need to be a ton of resistance. You can just use your fingers, tactile cues on your patients. Push your legs out, push your knees out as you descend and ascend. That's number 1. Everybody take a minute and just feel the difference